Welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we are diving into Amlodipine, a medication that's daily fixture in community pharmacies, hospital wards, and outpatient clinics. If you have ever reviewed a chart or filled a script for hypertension or angina, chances are you have seen amlodipine more times than you can count. But here's the thing. As pharmacists, we know that just because a drug is common doesn't mean it is simple. Amlodipine may be familiar, but is also frequently under-monitored, misdosed, or assumed to be benign. In reality, there are key pharmacist rules to play in catching dose-related edema, identifying CYP3A4 interactions, counseling on statin dose limits, and optimizing therapy in patients with complex comorbidities. In this episode, we will review the mechanism, clinical role, dosing, safety considerations, drug interactions, pharmacist-led case interventions, and finish with a rapid-fire recap. As always, our goal is to make sure you are catching mistakes before they catch your patients. Before we get into it, do not forget to subscribe to the podcast, share this with your pharmacy friends, and if you haven't yet, connect with me on LinkedIn. I would love to hear your amlodipine stories, catches, and questions. So, what is amlodipine actually doing? Amlodipine is a dihydropyridine calcium channel blocker. It inhibits L-type calcium channels in vascular smooth muscle, causing vasodilation. This leads to reduced peripheral resistance and ultimately lower blood pressure. In the setting of angina, it reduces myocardial oxygen demand and increases coronary blood flow. Importantly, it does all this without significantly affecting heart rate or AV conduction, which makes it safer in patients with conduction issues compared to verapamil or diltiazem. We commonly see amlodipine used for hypertension, chronic stable angina, and vasospastic angina. Off-label, it is sometimes used for Raynaud's phenomenon, though not as commonly. The standard starting dose in adults is 5 mg once daily, which can be titrated to 10 mg daily as needed. In elderly patients or those with hepatic impairment, pharmacists should flag when the starting dose is too high. 2.5 mg daily is safer in these groups to avoid hypotension and dizziness. One advantage we often counsel on, no renal dose adjustment is needed, which makes it a very accessible option in patients with CKD. Now, to the part pharmacists see firsthand, side effects. The big one, peripheral edema. We see this daily. It is dose-related, which means the risk increases as we go from 5 to 10 mg. Mechanistically, this happens because amlodipine causes arteriolar dilation without venodilation, leading to fluid extravasation into peripheral tissue. So when a patient shows up with bilateral ankle swelling, it is on us to assess. Are they on amlodipine? At what dose? Are they on ACE inhibitor or ARB, which might mitigate the edema? And here is the pharmacy perk. Do not assume we need to stop the drug. Sometimes reducing the dose or adding a vasodilator with venous action like an ACE inhibitor helps. Other common side effects include dizziness, flushing, headache, and occasionally gingival hyperplasia. Notably, it does not typically cause reflex tachycardia, which differentiates it from shorter-acting dihydropyridines like nifedipine IR. Now, let's get into the interaction zone. This is where pharmacists shine. Amlodipine is metabolized by CYP3A4, which means CYP3A4 inhibitors like diltiazem, erythromycin, azole antifungals, and grapefruit juice can increase serum level, raising the risk of hypotension. On the flip side, CYP inducers can decrease its effectiveness. If you see a patient on multiple antihypertensives, or if they are hypotensive on a standard dose, it is worth asking about concurrent 3A4 inhibitors, which often slips under the radar. Another huge catch we make in pharmacy, the simvastatin interaction. Amlodipine increases simvastatin concentrations, and the maximum safe dose of simvastatin is 20 mg when combined with amlodipine. This one is easy to miss, especially when patients are on combo antihypertensive lipid-lowering regimens. You will often see simvastatin 40 mg plus amlodipine 10 mg walk in together. That's your cue to call the prescriber and suggest reducing the statin dose or switching to an alternative like atorvastatin or rosuvastatin. Let's take all this into the real world. Picture a 72-year-old patient on amlodipine 10 mg daily presenting with progressive ankle swelling, no CHF, no renal impairment. As the pharmacist, you suspect dose-related edema and recommend to the physician either reducing the dose to 5 mg or adding an ACE inhibitor if not already present. That's a pharmacist intervention that prevents the drug from being stopped entirely and maintains blood pressure control. Now, a simvastatin case. A 55-year-old male is on simvastatin 40 mg and amlodipine 5 mg daily. You catch it while reviewing his refill and flag the statin interaction. You call the prescriber, who agrees to switch simvastatin to rosuvastatin 10 mg. That's the kind of catch that protects patients from statin-induced myopathy. One more, a 60-year-old man with heart failure with reduced ejection fraction is still hypertensive despite being on lisinopril and metoprolol. Amlodipine is added. You might pause here. While amlodipine is not contraindicated in heart failure with reduced ejection fraction, it also does not improve survival. Unlike ACE inhibitors, beta blockers, or SGLT2 inhibitors, you reach out to the prescriber and suggest optimizing other mortality-reducing agents first. That's the clinical mindset we bring. Alright, time for some rapid-fire Q&A. What is the most common side effect of amlodipine? Peripheral edema. How do we manage amlodipine-induced edema? Reduce the dose or add an ACE inhibitor or ARB. Does amlodipine require renal dose adjustment? No. Can it be used in patients with heart failure with reduced ejection fraction? Yes, but it does not improve survival. What is the interaction with simvastatin? Amlodipine increases simvastatin levels. Maximum safe simvastatin dose is 20 mg daily when used together. What food should patients avoid? Grapefruit juice due to CYP3A4 inhibition. Does amlodipine affect heart rate or AV nodal conduction? Not significantly, unlike verapamil or diltiazem. That's a wrap on amlodipine, a drug we see every day, but one that gives us opportunities to intervene, clarify, optimize, and protect. From peripheral edema management to statin interactions, from renal-friendly prescribing to nuance combo therapy in heart failure, pharmacists are at the center of amlodipine optimization. If you found today's episode helpful, do not forget to subscribe, share it with your pharmacy colleagues, and jump into our WhatsApp and Telegram communities. You will find the links in the episode description. And if you have made a clutch amlodipine catch or want to share a tricky case, I would love to hear from you. Connect with me on LinkedIn and let's keep the discussion going. Until next time, this is Momin Wali reminding you, catch mistakes before they catch you. See you then.